shape of your abutment dependent on the insertion depth, for example, of your implant, but also the position of your implant, of course. And if you don't have enough insertion depth, then of course, it's difficult to achieve the perfect emergence profile, and maybe it's difficult to clean, and maybe you can see the restorative component, the material and stuff. So let's take a look at the clinical case. This patient was referred for an implant treatment. There was a failing central incisor, here the left one, a pontic, and now the idea was to place 1 or 2 implants. But what is the perfect position for the implants? Is it 1? Is it 2 implants? So we analyzed the case, and I always use the face and pictures and also models in order to analyze these cases. And you can go for the smile design of Christian Coachman, for example, but there are many ways to analyze these kind of cases. So we looked at the proportion of the teeth and also the soft tissue, and we made a new outline and tested this with a wax up and a mock-up in the face of the patient and discussed with the patient. So we had now a goal that we defined with the patient together, the mock-up. So we come to a surgical treatment plan. We want to do a recession coverage on the right lateral. We want to place an implant, just 1 in the central position of the left, the left central incisor, and do a pontic on the left lateral incisor and a connective tissue graft in order to give volume to that area for pontic. So this is the new implant position. We cannot really focus on local landmarks. We have to go through all this analysis and do a planning and then accomplish this new implant position. Because if we just use local landmarks, we will end up completely without any restorative planning. So the restorative planning has to go first, and then we will find this implant position, which is here in this case 3 to 4 millimeters apically of the future soft tissue margin. So it has nothing to do with the tissue you find there, more or less. You want to define where you want to have your tissue in the future. So we placed an implant here in an immediate approach, and we augmented the area, the ridge, with the connective tissue graft in the same session. You see here healing abutment in place and recession coverage on the right lateral incisor. And after osseointegration, we placed a temporary in order to wait for maturation of the tissues and mold the pontic area. And this is the final result. And you see the superimposed X-ray. So we went for just 1 implant because we know 2 adjacent implants in the aesthetic zone are not very predictable in order to create papilla between the 2 implants. So this is the final smile of the patient who asked for a complete makeover of the situation with crowns, veneers, implant, and pontic. So next case is this young man, and he received an implant when he was 16 years old. Now he's 30, and you see the aesthetic situation, and also intraorally we see infected tissue, mucositis, and if you take a look at the X-ray, he lost bone there, you have separation, and we plan to remove this implant. Actually, you see this abutment design is quite striking with this bottleneck abutment design. So now he asked for a new implant and a new crown. I said, this might maybe not look perfectly. So what about the gap? You want to close the gap? Yeah, of course you can close the gap, but he has no idea how he will look afterwards. So we give an idea to him, we define a goal, and we make a mock-up. We go for a wax up and a mock-up and show the patient this is what we could achieve if we play with the proportion of the teeth, and if we make veneers, and this might be what you are looking for. But now you have a discussion with the patient, you can define a goal and talk with him over if this is what he desires. So what we do today, and the possibility we have today, is that we use all the information together with the data set of our cone beam CT scan. We can scan the clinical situation, we can scan the setup or wax up, and we can then plan for the implant position and align it with the data of the CBCT scan. And then we have a surgical guide and can accomplish now implant position where you can do a screw retained restoration and also have a restorative driven planning. And this ITI recommendations, they go in the same direction for what we call static computer aided implant surgery. This is what I just showed you with the stent. And they say it's an additional tool for comprehensive planning and surgery. So it's not the only answer, it's just additional information. You should go prosthetically driven. And how do you do this? With surface scans that include the prosthetic planning. And they should be aligned with the CBCT imaging data to improve the implant position. And also those surgical guides should be digitally designed on the surface data scans, which have been aligned with DICOM data. So not only on the DICOM data alone, because this will not really fit, it's not accurate enough. And this is what we do today. So now you see this patient here with the setup, you know, this acrylic teeth, just a setup in the mouth to give the patient an idea where we could go. And then we do again the planning, we superimpose all the information, the surface scans, and you see after the surgery, the restorative phase. And now we can fabricate a screw retained bridge. And if you take a look at the result, it looks pretty nice, but it's not perfect. Why? Because you see here the alignment of the soft tissue is not perfect because we didn't build up enough tissue actually vertically, because we were missing some information. And this is a problem because with these kind of stents we have today, you cannot rely only on the software, on the position of the implant. We need also to use our brain, and we should go computer guided plus brain guided. What does it mean? It does mean it's not only about computer guided surgery, it's also about taking a look at biology and some more information. And this is what I like to have as a surgeon. Of course, I like the guided surgery and I can place the implants in the right angulation and position, but still I want an additional information. And you see here this stent, it's a stent where you can see where the future soft tissue margin has to be, and also the tips of the papillae. So please don't feel outdated when using analog tools. It's still very good and makes sense to do that. It's not only the three-dimensional planning with the computer. So how do I use this? You know, I want to have the information during the surgery. Where's the crestal bone, of course, from the neighboring teeth that don't have any periodontal impairment. I want to know where the tips of the papillae should be in the future, and I have to see that it's underlined by bone. Otherwise, I have to build up some bone, like in this area. You see here's not enough bone to support the papilla. And I want to see also the future soft tissue margin. Here you can see where the future soft tissue margin has to be. And then I can decide where do I place the implant, of course, and where do I have to build up some bone and soft tissue for the future. And then we can end up with a nice soft tissue that is molded with a temporary in this case. So I come to the last case. It's a female, 50 years old, and in this case, she had a terrible restoration in place, an old bridge. And now it's a problem to do a mock-up, because if you add volume to this, it looks even worse. So you cannot do a proper mock-up in this case. This is why we removed the bridge. And you see here's a failing central incisor, this very long bridge work. And we were planning for implants. And we decided to now go for a temporary at first, just to test drive the new situation. You see it looks pretty nice. Also speaking and eating and laughing was not a problem. She adapted this functionally very nicely. And then we plan from this on, because we test drive now the new situation. And again, we do a scan of the clinical situation, a scan of the temporary, and align this now with the CBCT data set in order to see if it's a feasible implant position. And then fabricate a printed guide in this case to have the perfect implant position. But in addition, I wanted to use this like a shell temporary to see the alignment of the, or like, let's say the crestal bone. Where do I have to augment? Also for the augmentation, you need a kind of information or reference. And these kind of guides here, you don't have really good access to the surgical field. It's just for the drilling, but you need more information. And I like these kind of information during my surgery, because bone augmentation is most of the time involved when we do implants in the aesthetic zone, and we need a reference for this. So the X-ray after the surgery, implant positions, the temporary in place, and then what we do is fabricate some individual healing abutments to mold soft tissue, just to place them under the temporary. Otherwise, you have to do a complete new temporary that's implant born. And in this case, we can save this money and just go for these individual healing abutments, and then mold the tissues, wait for maturation of the tissue, and then place our final restoration, which can be screw retained or cemented on individual abutments. I know Uli doesn't like cementing very much, but I think if you have an individual abutment, it's also a nice and possible solution. So this is the smile of the patient before and after. And this is the way today we think that we can achieve predictable results in the aesthetic zone, that we have a restorative driven planning for the patient. And of course, we have to restore the tissues. So the conclusion for the last 20 minutes is we have to analyze the case, and we can look at the local landmarks, but they work only in selected cases. If you want to duplicate a central incisor, then you can go for the local landmarks. But if you have to redesign a smile, then you need to define a treatment goal with the patient and test drive it most of the time with a mock-up or with a temporary. And then I think restorative driven implant planning is mandatory, because otherwise you will not find the perfect implant position, and it's not really predictable then to restore the smile. You can go digital or you can go also analog. I think digitally derived surgical guides are nice to not touch any anatomical structures. But if you just want to have the information for the aesthetics, you can also go analog. But it's far more precise to go digital, of course, together with some analog informations. So a surgical guide is crucial, not only for the implant position, but also for augmentation of the underlying bone. And you have to respect the biological width. That means you need to have sufficient insertion depth. And this is dependent on the implant system you use, of course. And also you have to think how to design the transmucosal component. And I think there will be a lot of research in the future. What's the perfect shape of the transmucosal component? Today we use very slim abutments and then flare them. So we start very thin in the connective tissue compartment and then flare them coronally to develop the anatomical profile. And of course, always augment hard and soft tissues if needed. So thickening the soft tissue is, I think, an important component. I think Thomas will comment on that, also on the design of the transmucosal component. So thank you very much. This is the book we wrote together with some authors, and I'm very happy to have very nice co-authors that contributed to this, and it's now available in English and French. And if you have further comments or questions, don't hesitate to write me an email. Otherwise, I'm looking forward to the discussion. So thank you very much for having me today.
Arndt, thank you very, very much for this great lecture. It's not easy to cover what you covered in such a short time. We know that. I think we have a lot of points to discuss. For me, it's very interesting to see, and I'm very happy to see that you need two stands if you want to work in the aesthetic zone. And we will discuss this. Well, I have a lot of questions already coming in. I have a lot of questions by myself. It will be very interesting. And we go on with the next lecture. We go to Dennis. You all can see, if you look at Dennis' picture behind him, he has a beautiful scenery. We are a little bit jealous, Dennis, I must tell you. Yeah, we are sitting inside. You sit somewhere, I don't know, in South.
Well, I'm inside, but I have, that's a picture from the back of my house. So
great. Looking forward now to listen to your lecture, not your landscape. Up to you, Dennis.
Love you too. Ernst, that was a great presentation. Can you hear me?
Yes, thank you so much, Dennis.
Okay, video's okay. Can you see the video? Okay. We only have 20 minutes to cover a topic which we could spend the entire day on, is how to handle malposed implants. I think we see something like this, and I just wonder, when I see a patient that walks in like this, where was the dentist that put this in, the surgeon that put it in? I mean, everything about this is wrong from everything we know. But I want to cover today, in a short period of time, a little taste of how to fix these problems. And what I'm going to cover, I want to give credit to my great team that I'm with in New York and Manhattan. You know, many of you know, of course, Dr. Chu, Stephen Chu, but this is the group of Marion Brown. We have an orthodontist, Mark Hockman, periodontist, Paul Fletcher. That's me before I lost about 40 pounds. I'm a lot thinner now, thank goodness. Marion Brown's a prosthodontist, Richard Smith and John Zamzak, all prosthodontists. Guido is a prosthodontist, cross-trained surgically. Almost every one of them except Steve is cross-trained surgically. He's allergic to blood, so he doesn't like to do any surgery. But everybody else have cross-trained surgically. And we can't go anywhere without what? Our technicians. I think this is a critical piece to remember. And most of the work you're going to see today, the beautiful ceramics, is Adam. He's our main ceramist, and he has just been incredible. So let's move on. So what I'm going to do is obviously always have the patient in the middle of everything we need to do, patient's needs, financial and others. But I'm going to cover it from 3 different phases very quickly with just like 1, 2 cases for each piece, because we only have a short period of time. So first is the restorative dentist or prosthodontist. Then you bring in the periodontist or oral surgeon. By that I mean also any generalist who's capable of doing surgery, of course. Could be a prosthodontist, general dentist, but I'm saying surgeon in general. So I use the word surgery generically. I know most of the Europeans and Asians and South Americans do not necessarily, they do everything. And then I'm going to bring in the orthodontist with some of the most difficult cases at the end, because sometimes we need the orthodontist to do the kind of work that you will see on a predictable basis. So let's take a look quickly at each of these things. First, the restorative dentist. I love Mary's case. Mary's case shows you what a restorative dentist can do, someone who understands wound healing and understands crown contour. Now, Arnie Weisgold in the 70s talked about, at University of Pennsylvania, talked about under-contouring restorations. Flatten the contour, tissue moves coronally. Over contour, tissue moves up. We all know that, and that's why you saw, even in Arn's cases, some of the cases were too far forward. And that's what you're going to see is the main problem that we always see on the mid-facials. The implant was placed too far forward with too big an implant. Arn's mentioned that. So this implant's been there. She's been walking around like this for 8 years. And she has a hand in front of her face. And I said, she's a sweet lady. I said, Mary, why do you have the hand in front of your face? Well, she giggled and she said, well, take a look. She had this black thing sticking out. Now the dentist, I said, you go back to your dentist. She says, well, that's the best we can do. The implant's healthy. You got a tooth. That's the best we can do. That's ridiculous. This is a cosmetic failure. And although it's functional from a strength point of view, it's not aesthetic. It's obviously an aesthetic failure. So the first thing you have to check is the implant healthy. We'll come back to that a little bit later. But this is a key thing. Is the implant healthy? Is it worthwhile to even go after? First thing you'll hear me say in the middle of this presentation and again, is the implant is unhealthy and has a cosmetic problem like this, take the sucker out. Today we can reverse torque with different, almost every company has reverse torque machines, and they work probably 90% of the time. Instead of doing like what you showed Ernst do with the Corey's technique, we can now save that bone, although he did, and put it back. That was a beautiful case. Today we can reverse torque these out with very few exceptions. Otherwise, then do it that way. So even if it's broken. Okay, so we have this. The implant is healthy, but there's a problem. Past dental history, recession, right from the beginning. So we're going to move along here. And what are we going to do? Sorry. We take off, that's an abutment, obviously. And one of the good things here is that the implant was deep enough and the papilla are intact. So this is strictly a mid-facial problem. So can we fix this? And the implant is healthy. So when we take it off, you take a look at this distance here. Can you see my my mouse? Does it show? Uli, I don't know if you can probably, okay, I hope they can see my mouse. The first and most important thing I do when a patient comes in with this kind of recession, what do I look for? I take off the abutment, or before I even take anything off, I don't take anything off first. When I'm doing the consult, I look, the buccal is obviously receded. You know what the first thing I do? I look at the palate. And I look for this. Is it buccally and lingually that you have this deficiency, or do you have only a buccal problem and you have this beautiful piece of tissue here? That's the vertical blood supply that you need. This is a piece of cake, because that means that you have vertical blood supply. You don't have to do vertical augmentation. As you all know, that's difficult. Now, so this, we take it off. And Bert Langer showed us this years ago, 1994. He did this with teeth. Before he took a tooth out, he let the tissue overgrow the tooth. He cut it back. He cut the root. It was called decoronation of a root. Well, we're going to do the same thing. He took it off, and in 2 weeks' time, more tissue overgrew it. Beautiful. So then he could take it out and had more tissue to cover his graft. Well, we're going to do the same thing here. Dr. Chu and I wrote an article on this called Decoronation of an Implant. And what we do, the decoronation is simple. Take the abutment off, and what do? Don't leave it this way, because the bacteria gets in there. So what do? Take a cover screw and put it on top. But you got this powder tissue, put the cover screw on top and let it heal for a couple of weeks. Now, I thought I'd have to do a connective tissue graft here, and I scheduled her for 2 or 3 weeks later to now get some extra tissue. Let nature help you. Just don't be a cowboy and go in there and do everything right away. Let nature help you. Watch what happens. We did a bonded bridge, so the patient immediately had it out of occlusion, just bonded and spot etched to the adjacent teeth. You'll see that a lot in these cases. We put the cover screw on. There's the bonded bridge that was made with just some spot etching and leaving the space. Don't put a Pontic in there. Leave a space there so that the tissue can grow in. So I had the patient come back in 2 weeks. Steve put this on, and I had the patient come back in 2 weeks for me to do the surgery. But when she came back, I saw this. So what I said was, wait, that's really great. We went from this to this. It was working. I said, maybe we just got to give this more time. Maybe de-epithelialize it, let it heal a little bit more. So I de-epithelialized it and said, come back in 2 months. And lo and behold, most of this covered over. And so this is the article by Dr. Chu and I, 2013, in Compendium. And what you see here is the decoronation. Put the cover screw on, look all the tissue. No graft was done yet. Nature's connective tissue graft. Now, there is always a hole here. Why? Every time you do this decoronation, when you put a cover screw on, the bacteria sit in the cover screw hole, and the tissue will never completely close, never, unless you surgically clean it and cover over it. Otherwise, it will always have this little fistula. And you'll see this in a couple of these cases. So it's a hole there, even though, look at all that extra tissue. Now we got to expose it. The implant's far forward. See, there's the hole right there. There is 3 months. Now, I was ready to do the graft, but I didn't really have to. I did this all by changing crown contour. We had the depth to do this and change the direction, just like Arn pointed out. Here's Arnie Weisgold talking about flat profile. Let's go through this quickly. We just made little release just to get a flat post on. And that's what we did here. Just a release to get the flat post on. And there's the extra tissue at 1 week. Now it's going to move up a bit. It's going to move up a bit. Now this tissue was thick, so it came down, except for the hole. And we had the hole here, so it's not going to cover a hole. But this is a bonded bridge. It's not attached yet. Now we're going to attach it, sculpt the tissue by under contouring it, over contour where you need it, under contour where you don't need it. And this is what Steve then did this with the temporary on top of this. We waited a few months to see if we needed to connect the tissue graft. In this case, the tissue was thick enough we didn't need it. So we went from this, as you see here, to this, just by crown contour and letting nature heal. How nice. Look at that. 4 millimeters of tissue grown down, because the lingual tissue was the key and the papilla. Those are the 2 keys. And we thicken the tissue, then we put a straight ceramic abutment. As you see here, zirconium abutment, very flat. The key is flat, flat, flat. When Young talked about that, about creating this in vitro color of 2 millimeters of tissue, we had it. And so we just put that on, and then Steve made the crown. And we didn't notice how this would hold up, but obviously the tissue was healthy and we got what we needed. And here's a 10-year post-op. Survival was excellent. I never did a connective tissue graft here. This was nature's connective tissue graft. So it just shows you what crown contour, when the papilla are present, shows you what crown contour can do. 10 years later, tissue is held up beautifully. And she's very happy. Now, sometimes you need to obviously do some surgery. In fact, most of the time you need to do surgery. I just wanted to show you what a restorative dentist can do. Let's take a look at this case. Here's a midfacial problem, but she has no thick tissue here. Different than Mary, she has very limited thick tissue here. So we're gonna have to build this up besides down. We need out and down. What do I see here? When she walks in, and I see this all the time, what do I look for first? The palate. Look for the palatal tissue. Look how nice that is. Step right in. However, the question then is, how healthy is the implant? It's got to be healthy. I can't have any significant bone loss at all, because otherwise you're trying to regrow bone and soft tissue. Take it out if that happens. Don't even waste your time. But if it's only soft tissue like this, and you have that tissue on the palate, we do what? We do the decart. Look at the position. The question is it worth saving? But this was deep enough that we felt we didn't have this time when we did this case. We didn't have reverse torque machines. So we knew we'd be destroying a lot of very healthy bone if we took this out. So I said, let me try and work with it. So Steve and I did something. So we did the decar. Look at how far forward it is. So we did the decarination, angulation, but we didn't even have a cover screw for this. We found a cover screw that at least went over it. We didn't even have the matching cover screw. This is not our case, obviously. This is the way patients walk in, put the cover screw on, and look what happens. Instead of doing the surgery back here, I'd have to pull this down, do a connector, but look at all this tissue that's missing. I have to pull it down, bring the mucosa down. The key is let nature help you. Give it a few weeks of decarination, a bonded bridge, not touching the tissue, and look what happens. This is 4 weeks later. Now I still have my hole. Remember, you always have the hole because the bacteria get in this cover screw and will never completely close. It'll cover over it like you see here, but it'll never completely close. So now I can make an incision down here at the crest, move this out and put in a graft underneath and build this up. So there's what you have it, Langer with the connective tissue graft. I opened it up. Now, what do I do here? I do papilla sparing incision. Now, this should be a major part of our discussion. I know Uli and I have discussed this numerous times, and Ernst, you in some cases did this, in other cases you open the papilla. If I have the papilla there, I am adamant about this. Not everybody's as good as Uli and Ernst at doing these things. And people, if you have that papilla there, like you have here, the last thing I want to do is to fix a mid-buccal problem, is to create my own periodontal papilla problem. Recession of papilla is very serious, as you know, and difficult to get back, which we'll talk about in a minute. So I do papilla sparing incisions like this all of the time if the papilla and the attachment on the adjacent teeth are healthy. I'm going to take a thick connective tissue graft, as you see here, as thick as I can get. I'm going to put that underneath. I need soft tissue here. She has bone on the implant. I could have built some bone up too, but I need tissue because I got to create a new emergence profile. Place the flap. There you see that, in fact, we got some swelling, and the ovate pontic, which was relieved, now is touching the tissue and creating a little indentation. The biggest problem is uncovering these without touching the papilla, because it's so far forward. This creates an opening here, and you don't put a temporary on. Put the flattest emergence profile you can, straightest, flattest abutment you can find, because these can't close because there's no elastic fibers in the attached gingiva, and that's what the problem is here. So you push that out. Here's the 4-week healing. Now you start to sculpt it, create a temporary. I'm going to move through this quickly, and Steve makes a temporary. The contour that you saw that Ernst said, the key in this case is that it was deep enough for us to save, even though it was misangled. And that was the key, flat, flat, flat. And here it is, the initial healing with the temporary mucosal blanching, which will go away. Here it is 3 weeks later. And here you see the sculpted tissue, minimalized in front, heavy on the back. We got the tissue plumped out. So we started with this on the right. And we end up with this and changing contour. Now this has to be a metal abutment. You can't use ceramic here. We gold plate it because metal is stronger and will hold up. Ceramic would break when you have the whole post sticking out. Now maybe you could put an angled abutment on this. We didn't even have the parts for some of these implants. That's a separate problem. But here's the healthy implant, and here's the final case in place. There's the final case in place. So we started with this, and we ended with this. Now, people always say, you get a scar here. That's an indentation, it's not a scar. Attached gingiva does not scar. There are no elastic fibers in attached gingiva. That's why we can do a gingivectomy and get away with it. It's the only part of the body that does not scar is gingiva. Mucosa scars, but attached gingiva doesn't. It creates a groove. That groove to be plastied if you want, or it doesn't even. This patient was so happy, and she came in with this. She had a groove there to begin with, see it? So it's not like she didn't have it. How does it hold up? Here's 5 years later. So I'm showing you a 5-year result. So I showed you a 10-year result, is a 5-year result. And you can see that this is a healthy environment. We created something that looks good and holds up well. And there it is 9 years later, okay? It may have happened to some migration of the tooth. It looks a little shorter now. That's a separate topic that we can talk about, but that's not the relationship to today. What about Diane? Diane had these 2 implants placed by another clinician, and she was horrified. She wouldn't even let the guy put the crowns on when she saw what they looked like, because the tissue is missing. There's a horrible cases when you look at these. Look at the indentation, look at the bone loss. The angle is off. Everything about this case was bad. And she was a very, very finicky lady. Look at her smile. That's not an exaggerated smile. She shows everything. So what are you going to do? Do you take him out? Well, it certainly was a thought, but she's deficient in tissue and bone. You can see them here. You see the deficiency. I think it's pretty clear. The one good thing is she has what? She has papilla. And I don't want to touch those. Now, I know a lot of people, and we can talk about this, would open up probably cuspid to cuspid minimum, do big grafting, beautiful grafting. And if the bone's thick, you get away with it. But I have a career of my practice. My practice is built on fixing problems of the papilla that people were not the capable people that should be doing it. Open flaps, didn't do proper grafting, different than what Uli does and Ernst did. You wind up losing the papilla, and even though it was there, and then you fix the buckle, and now you have a short papilla between 2 teeth, a black triangle. So take a look at depression. I'll go through this quickly. So what did we do? Sorry. So we did the what? Decoronation. Okay, let's look at what happened. There's a decoronation. Now we let it just for 3 weeks. Now notice there's always a hole there. See? But now I can go and I have some extra tissue. I can go both apical to that at the crest and move that tissue out. Notice papilla sparing incisions. I'm not going to sacrifice the papilla for the midfacial. It narrows my distance here. It's okay. It's not a problem. I'm going to open it up. She had bone there because it was angled palatally, but now I'm going to build this up. She had a big depression here. I can go as high up as I need to. There's the tissue. I can clean that out. There's the distance. I'm going to totally release the flap. That's the key. Everybody knows that. Uli did that. Everybody's done it. Stefano Urbanolo, great clinicians. Everybody learns how to release it, or else you'll have failures. Then I put a graft in, and then I put what? A membrane over that, and the connective tissue graft over that to cover over the hole. So I got a triple layer. I've got bone graft where the bone is deficient. I put a membrane over that for GBR, and I put extra soft tissue over that from the palate, as you see here, a triple graft. Covered it over, sutured it in place, leaving my papilla intact, as you see. Here it is at 1 week followed up in my plumped out tissue. Here's 1 week follow up. Here it is. Now we made a temporary. This temporary, the teeth were coming out, so Steve made a hole for the moment in the temporary until we got a new abutment in. But look at the extra tissue that we got. There's the temporary out. Then we made a custom post. We had to re-angle it. And here's the final case in place. Tissue is plumped out. I think we got a nice result. Here you see the angle of the implant that was put in incorrectly. It's pushed out well enough. Here you see the right side. She had both sides. I think we got pretty good response. The papilla are intact. Notice you don't see any major grooves because the papilla, the attached gingiva was intact. And here's the before that I showed you. And there's the after, both laterals. I think we got a decent result. I think I'm very happy with the thickness of the tissue, the profile, the position of the height, everything about it. We've got it to come down. So there's the final case in place. And I think we're in pretty good shape. So midfacial implant decoronation to me is the key. Okay, get some extra tissue, tooth-supported provisional restoration. Connective tissue graft is usually required, of course. Manage the restorative contour with your provisional. And now the last case I want to show is bring in the orthodontist. Right? I've shown you midfacial right now. When I have the papilla missing, we got to go further. The interdental problem and the combination defects. So let's just take it. We know what orthodontics does. I, Stephen Brown, certainly the Salama and Garber, Francesco Amato and myself published this, and Mark Hoffman and Archu and myself published a summary of all of these things and some extra work there if you want to go back to that. So we're going to force her up the tooth, and you take a look at Kristen. We actually published this case, but I think it's important to take a look at. Obviously, there's a tooth size discrepancy. So we take a look at Kristen and take a look right here. The real problem, she's missing attachment on the mesial of the lateral, right in here. That's a whole different architecture. And look at that compared to this papilla on this side. Completely different. Completely different. So this patient had a patient that had a graft after a failed implant. The implant was placed too close to the adjacent tooth. The implant failed. And look at the bone loss on the adjacent lateral. She said, I never had anything like that before. I never had this problem before. She's lost 4 millimeters here, 4 to 5 millimeters from here to there. The CEJ's down here. So what do? It was too close, and you see the result. So the first thing we do, we have to check this out. That's the problem. We're going to force her up the tooth to bring the attachment down. That's the key. So this is the fibers on the tooth stay with it, and it will come down and create supercrestal fibers, and that's what we want. We want to bring the tooth down and coronally position it. Now you take a look at this. There's a tooth size discrepancy, so the central is going to have to be built out, of course. That's incorrect. So this is Dr. Chu's gauge. Ufridi makes it, I think, for him, that you can see based on the proper height and length, you then know it's 80% height versus width. Ufridi makes that. So Steve came up with a cute little item, and you see what the red line is here. This should be out to here at the top of the red line. So we obviously know it's 80% height and width, golden proportion. That's a separate thing. But take a look. We cleaned it up. But what do you see here? You make it temporary. Whenever we have to do prophylactic endo, because we're going to force her up that tooth. Don't play the game and just see if it needs endo. This is part of the game. You may or may not even save it. But right now, I got to bring this tissue down. My goal is to bring this tissue down all the way down to here. And the first thing I need to do is put a pink temporary on. Use pink acrylic, so I can see how much shape it is. This is a guide for the orthodontist, in this case, Dr. Hockman in our office, Mark Hockman. But it gives Steve put this on there deliberately, so we can see everything in pink we have to rebuild to get a good result. Midfacial, buccal, height, and papilla height. And that's going to be our guide. So we have to see whether or not we can do this, and that's our guide, visualization. So what you see, we have a big smile. Look at, she shows everything. So what you see here is the orthodontics. We bring it down. I'm not going to go through this in length now. You shorten it, keep shortening it, bring it down. And when do you stop? Now the distal is going to be too much tissue because that was healthy. But the mesial, you bring it down to about the same point as the adjacent healthy tissue right here. So this was up here. Now we brought it down to here, and that's what we want. Then we can place the implant. Now, always do your advancement, or don't put your graft in first or your implant. Always bring your papilla down first. Why? It gives you blood supply. And then leave it alone and do papilla sparing incisions. So don't just put the graft in first. Never do that. Always bring your tooth down orthodontically. It builds up blood supply right in here. Then you can get a more easy surgery for the graft. Now you notice also papilla sparing, but look what happened. This root was dehisced, but there was no probable depth. It was healthy, just long gingival fibers. We're going to still keep it because cosmetically, this is what I want to do. Place the implant in the proper position. Place the implant in the proper position for the arch. Of course, it was deficient in that respect too. I then built up bone, connective tissue, collagen membrane, leaving the papilla intact. Modification of the temporary. And then there's too much tissue here that's going to be brought down. This is what we started with, and this is what we ended with at this point. So let me go back again. This is what we started with, remember? And this is what we ended with after orthodontics. It's not perfect, but it's pretty close. Too much tissue here, that's okay. And then we just here we have to splint the natural tooth to the implant. We can talk about that. Splint the natural tooth to the implant, secure it. And as long as you do it rigidly with no interlocks, this is what we do. It's rare that we do this, but when we do it like this is for aesthetics. To hold the mesial of this tooth has gingival fibers on it and has attachment, and it's healthy. There's no pocket depth here. So what you see here, we're holding this tooth in place and saving it because I don't want to lose this papilla. It's got supercrestal biologic width, and that's what I want. And here's the final case in place. There's maybe too much tissue here. But notice it's still leaving a little bit short, shrunk a little bit, but we have at least a scallop. This is what we started with the papilla way up here, and this is what we ended up with early on. You can see we got at least a scallop. Wasn't perfect, but it should be down to here ideally. But it at least has enough that we wound up having a nice scallop and not this big, terrible recession. And there you see it in the smile. She shows everything. How's it hold up? Here it is 4 years later. I think it holds up very nicely. 4 years later, you can still see that she's doing well with it. And this is, I think it's about 5 years or 5.5 years now. So I end there. I tried to give you a quick summation of what I do with the prosthetic surgery. I'm prosthetics alone, prosthetics with surgery, and prosthetic surgery and orthodontics together for the papillar and more advanced cases. So I look forward to Thomas's presentation and having the discussion with everybody. So I know we only had 20 minutes. I'll see you at the discussion time. Thank you.
Great job, Dennis. Thank you. Thank you very much. I think you really showed us very difficult cases, and many of us would have unscrewed the implant and start all over again. You showed us how you can solve this problem, and it's very impressive what you did from terrible cases to nice cases.
Coming from you, I'll take that as a great compliment. Coming from you, I take that as an ultimate compliment. Thanks, Uli.
Thank you very much for your great lecture. We pass over to Thomas. Thomas' lecture will be focused mainly on prosthetics. Thomas, are you ready? We really look forward to your lecture, and then we have a nice setup for the discussion. Please, Thomas.
Yes, so everything's fine? The screen is okay?
Yep.
Okay, so I want to welcome everybody to this unique session. And I think that everybody thinks it that way, that these difficult times really change the way you look at things. So I think everybody and the lecturers and all the people who listen already start missing this lively human communication. And I hope this will be over soon and we will meet each other on the podiums or in the lectures where we used to do that. I'll add my sense, nickel, to this nice conversation about talking what prosthetic concepts can improve results in aesthetic area. And when we agreed on this session, I kind of a little bit thought about it a little bit more deeper. At the end of the day, what is the job of prosthodontist in these cases? Because majority what we can see depends on the surgery, on the position of the implant, and on the technical work. So where is the prosthodontist to deliver things like you can see here? And what is the role of prosthodontist to have a nice profile like we see here and to have nice bone stability as you can see it on the X-ray? Again, what is the role of prosthodontist? What should we do to improve these things and to like, how to say, not to spoil good surgery which was done before us? And I'm sure that everybody remembers, at least I do, like, 15 years ago, these were like, something magical things, before and after cases. Like you have a bad situation here, like a long implant crown, and suddenly for some magic, you have a shorter crown. And sometimes even I remember lecturers saying that we didn't graft anything, we didn't change everything, it was done just prosthodontically. So of course, now I understand that this was not quite true in those majority of the cases, because here we can see this was a malpositioned implant and nothing you can do here prosthetically, in my point of view, because the position is bad, and just by removing it, we already see how it improved. Just by removing the implant, we see that tissues become better. And with a good position of the implant palatinally, we practically, and of course with some grafting and soft tissue grafting, we can improve tissues to the extent which is acceptable. But as I mentioned before, first comes a good position of the implant, which is done during the surgery. And I come to thinking, like, because as I said, looked at it a little bit philosophically, that if you have bad position of the implant, I mean, probably now it's better to remove the implant and to start over. Because of course, in not all the cases you can do that, but now a good position of the implant is a must. And if position is good, then the work of prosthodontist gets reduced. Of course, there is some, again, psychological point of view, because here you can see that in this case, before we removed the implant, actually we had better stability of the bone compared to this new redone case. But of course, as I'm saying, that the bone stability is important, but it's always must be put in the context. Myself, I would prefer this implant with a little bit of bone loss, but a normal position and normal crown compared to this zero bone loss implant and a bad crown. So again, it's always a little bit dependent. I come to the idea that, of course, in aesthetic area, sufficient depth of the implant and sufficient sagittal or palatinal position is the most important things. So vertical soft tissue thickness, deepness of the implants is important for biological width. And of course, horizontal tissue thickness is important for stability of the tissues. When I lecture about biology, of course, my point of view is say that vertical soft tissue thickness is very important because it was neglected for so many years that nobody really paid attention to that. However, when I think about anterior cases, then I would say that horizontal tissues, the horizontal tissue thickness is the ultimate factor. It is very nice, good drawing from my book, when you can see all, let's say, 3 biological factors in the same slide. That's when you can really evaluate and understand what we're talking about. That vertical tissue thickness is similar to attached tissues because they both have vertical component, but it's not the same. And horizontal tissue thickness is different, of course, and more important, I think, in anterior region than compared to the posterior region. This brings me, of course, to the title of the book and the title of, let's say, all my philosophy, which I've been now talking about 10 years, that ultimate goal is to have stable bone. And starting from the placement of the implant, till the follow-up. And again, we have a lot of proved things how to keep the bone stable. So in my opinion, bone stability is not an issue anymore. And in aesthetic area, of course, we need to have tissue thickness horizontally with position of the implant, and that would be practically major things. Now, of course, there are some prosthetic factors which we need to evaluate, and there are more, but I kind of thought to list 3 of them. In my opinion, most important and important is that these factors prosthodontist can select. It's up to him, because position of the implant, if you're not placing implant, is of course predetermined by the surgeon. First thing, of course, what we should do is select between cement and screw retained. And to really prove my point, I'm gonna show just one case. This is 10 years old situation. This is what you can see 10 years ago. Again, I'll start with a good position of the implant, thick tissues vertically, thick tissues horizontally, and papilla, and that's an ideal situation you can have. And this was restored 10 years ago. And after 10 years, we can see that situation is quite okay. Also, especially talking about this area, because we know that there is supra-eruption of the teeth. So if we have after 10 years implant in that position equal with the crown of tooth, we already think that it's really good. But when we saw the X-rays 2009, 2013, 2018, suddenly we see bone loss and perimplantitis. And where did that come from? Because for like 7 years, nothing happened. Oh, cement happened. When we remove the restoration, you can see the particles of cement glued to the surface of individual golden abutment. And also you can see the surface of the abutment itself. So we can talk about cement and also tissue smoothness, material smoothness here, because those factors are important to develop perimplantitis. So that's why I think that actually cement or screw-retained is important factor, and selecting cement screw-retained restorations is the first thing we should do. In my opinion, it's ultimate goal because you reduce so much complications by not having cement. But if I have to finish up this case, remember we just stopped here. Yeah, and then we remove the cement, we just clean the abutment and put it back. You see what's happening with the bone is remilionarizing. So it's not uncommon to see it when you really see the problem, and if you remove it, you can regrow the bone. Of course, there are several factors. The patient must be certain type, but generally talking, this is important. So screw retained, that would be my first thing, first recipe. What not to have aesthetical problems, not to have problems in aesthetic area, start from good position of the implant and then screw retained restoration. Another option is, and previous speakers just really also talked about it, and actually the emergence profile of the restoration, which comes, of course, with the position of the implant. Because when the implant is positioned in a good 3D position, then the emergence profile may be not that important. Of course, it's important, but we can play around it. If the bad angulation of the implant, then emergence profile becomes the crucial part. And here I'd like to differentiate between two topics. One is if it's immediately placed implant and if it's healed implant. Because of course, if it's immediately placed, we must prepare our provisional restorations to have this kind of shape, not to have additional pressure on the tissues, just to support it. Not pressure is needed, because then you can really cause the recession and you can end up with the problems. Here you can see attached screw provisional restorations to the implants after the surgery. And when the implants heal, that's a different story then. Then we can play with the tissues, and like everybody, I think, said today, with a healed implant, the pressure on the tissues is, we should not be so scared of it, because pressure of the tissues actually, in my opinion, really is important to develop adhesion, how the tissues contact to our abutments. And if there is no pressure, you won't have the stability, you have the flabbing of the tissues. So when already implants are healed, you see again good position, thick tissues horizontally and vertically. Then we restore this with single screw retained restorations. And this is the final outcome of two implants side by side. And I think that I know that there is some pressure on the tissues for these implants. The last thing which I would like to discuss is material, because from which material the abutment or screw retained restoration is made is, I think, also important in my point of view. And we all know that both our soft tissues have plaque zone and adherent zone. Those are different zones. Plaque zone is contaminated, adherent zone is clean. And when you see this video, which I showed during the lectures, you can see the difference in cleanness of the zones. I mean, that's the function of biological width, what you can witnessing here, because when it's clean, it means that the tissues can attach. And it's when it's dirty, when it's contaminated, you have a plaque zone. So apparently, we start to think that what kind of material has least attraction of the plaque, and also other qualities to develop stability of the tissues. Now, this is the ultimate goal, to have adhesion. And I think I consider this contact of the tissues to the surface of abutment an adhesion, a gluing. Like you glue two pieces of glass, you have glass, you have wet water and another glass. And if you glue them together, then you cannot separate, coadhesion. So this is how I think really the tissues should adapt there. Now there are, of course, you cannot find the study which say that if you would use zirconia abutments like from here, your implants will last longer compared to, let's say, if you use titanium abutments. We're not talking about, let's say, survival or success of the implants. However, I think we already have passed this threshold when we think that implants are integrated and we take it as a norm. We must now, what we're discussing, what material really influences the tissues. And 5 years ago, I did a systematic review. And for many years, I somehow did not really look at it because, well, I did not maybe thought that it's important, let's say, from that point of view. However, recently I looked at it and I found that we really found a very strong outcome from that review. That in the review, I included the studies, split mouth studies. It meaning that on one side, patient had restoration of zirconia abutment, and on the other side, patient had the restoration of titanium abutment. So same patient, split mouth study, you have no better design. So this is the strongest design you can have in the world. And what they found in those studies, and we did analysis, that superior aesthetic outcome measured by pink aesthetic score around zirconia abutments. And we all know that pink aesthetic score actually is the only objective evaluation of aesthetics. When people say, I think that tissues look better around zirconia, what does it mean better? I mean, maybe in Lithuania better is this, and in Germany is different thing. So pink aesthetic score is actually the only thing we can objectivize and make feeling into numbers in terms of aesthetics. So for example, here, I mean, if I calculate this case, you have papilla, you have tissue contour, you have gingival level just equally to the tooth, you have good alveolar process, coloring and texturing is good, and I can write 14, the best number for this evaluation, and there was zirconia abutment behind that crown. Now, I'm not saying that only zirconia helps, but it's been, we can say scientifically, that you have better tissues around zirconia compared to titanium abutments. And that's, I think, very powerful thing, especially when you look that sometimes when you remove zirconia restorations from the implants, you sometimes have adherence of the tissues, leftovers of the tissues on the polished zirconia. And around glazed restorations, you have like remnants of the breakfast, yeah, or I don't know, supper, not some kind of cells. And we see witnessing, actually, this is one of the cases just recent, 2019, 2020, look what happened. And there is no augmentation. This is, I call, prosthetically driven augmentation, the growth of the tissues, because these were zirconia restorations, super polished. And we also can see that the effect it's on the bone is also good. Now we can discuss what kind of materials, why the zirconia is good, structure, reduced bacterial adhesion, fibroblast adhesion, and all this culminates in the polishability, in my point of view, that from all the materials which were available now for restoration of the implants, polishing is, zirconia can be polished the smoothest. Now we have a special protocol how to polish zirconia. Again, I must emphasize that I would not consider it as an ultimate savior of the implants and the tissues, but in our experience, it really works well. And I see only good growth of the tissues around super polished zirconia, just case I just showed before. And let's look also in other cases, which I'm now about to show. So zirconia can be smooth, and porcelain or glaze is the roughest material. This what we saw in our studies under the microscope. That's why. we really tend to super polish our subgingival part of zirconia, do not glaze it, do not cover with ceramics, and that's the protocol which we are using. And I was really, some years ago, was very encouraged by the study from Liège, from the Professor Rompan has shared with me. So they looked at what kind of cells do they see around this removed restoration. When you remove restoration from the tissues, there's sometimes adherence of the cells. They wanted to see what kind of cells. And on the surface of polished zirconia, they did not find fibroblasts. They find epithelium, because epithelium is the cell, our protective cell. It lines the surface of zirconia and glues to it. That's why super polished zirconia, in my point of view, is better, because for epithelium, the smoother the better. Then it glues just a little bit better. Let me conclude actually with this topic with one of the clinical cases where we will see, in my opinion, the effect of super polished zirconia. Now here we have an restorable root, extraction of the root, positioning of the implant palatinally, immediate provisualization, so grafting, and also attaching provisional restoration. Of course, if you're doing canine, you must take it out of the occlusion and also take out of the movements. This leads to the nice healing. And what I can see before the extraction and implant placement and after, almost all the contour is being preserved. And I see the tissues, again, nice, the shape it was preserved. I mean, this protocol, everybody is doing it. It's nothing really very difficult or interesting or new. And then we have now delivery of super polished zirconia restorations. And I just want you to notice what's happening with the contour. So you have the delivery. This is after a few years follow-up. And this is, I think, after 3 years follow-up, we actually see the growing of the tissues, making it a little bit thicker. Now, this is just at the delivery. This is 3 years follow-up. And if you enlarge, you can clearly see the difference. Now, of course, just when I prepared this lecture, I started to think maybe it's not a good thing for anterior tissues. I mean, to have this kind of thing in anterior tooth, maybe it's not that good. So again, we maybe can have different discussion here. However, it's evident that super polished zirconia, really bone is stable here, and we can have growing of the tissues. Where I think we can use it always is in anterior posterior case. Here, this is when I saw this situation, it was excellent. So posterior, you see, we'd like to graft. I mean, I think everybody would say that we need keratinized tissues here. And sometimes we do zirconia restorations and do the grafting after, because we already have the contour of the crown. And so, in my opinion, sometimes easier to graft. But when the patient came back after a year, you can see that you have tissues which were not present before. And this was not grafted. I mean, this is identical from the start to the end. And now I think everybody would agree that you don't need graft here because the tissues are keratinized. This also brings me to the situation that super polished zirconia, I think it's also good for remineralization of the bone. And maybe I'm speculating here, of course, but this is the lecture, so we can afford to say things, not really scientifically proven sometimes, but at least in this case, we had bone loss after delivery because of the probably too wide restoration. But when I removed it and I really shaped it, make it thinner, we got it back. And again, doing nothing, we had complete remineralization of this implant. So if I would have to conclude and say what things are important, so of course I'll start with perfect implant position. That dictates tissue thickness And then already the work of prosthodontist is really not that difficult. You need a good technician, and I think all the cases can be solved. I would recommend polished zirconia, screw retained, and the special profile of the restorations in order to have a little bit pressure with the final restoration. With this, I'd like to thank you for attention and thank you for now waiting for a discussion. And you can find information in the book and also in my website, thomaslinkevich.com. And thank you for attention. And let's now start the most interesting part of the discussion. Thank you.
Thank you very much, Thomas. Can you hear me?
Yes, yes.
Great lecture. Thank you. And we will have to discuss a couple of things here, I think, especially about the fact whether the shape of the crown or the material of the abutment makes the difference, whether you see a reossification. I think Dennis will not really agree it's only about the material. But let's start with one question. I collected all the questions that came in. I tried to summarize them a little bit. And I would like to start with one question that goes actually to Dennis, because we have seen in the lecture of Arndt that he needs 2 different stents in the front area. How many stents do you use if you place an implant in the front area?
0.
0, because you already placed so many implants.
Exactly. Do I say that I've been teaching for years, obviously. I've been teaching for years, and the problem is that stents have 2. If you have a tube in the stent and you've designed it like Ernst has, beautiful. That's great. I'm not saying not to do it, of course. It is more accurate within a millimeter or so, even from an experienced clinician like all of us, here. So there's no question it's more accurate. But I've also learned that, so if you're a beginner or for a single tooth, I find it almost gets in my way sometimes, unless I want to take the time to make the tube. If you just have an opening at the top, like for a hole, which is classically what a restorative dentist gives a surgeon. When I say surgeon, whoever's doing the surgery, himself or herself, or an oral surgeon or a periodontist, you like a lower bicuspid or a molar. You got a hole based on the temporary that you waxed up beautifully. You made an omnivac and you made a hole in. That's a completely different kind of stent. A guide, I should say, than what Ernst was doing with the full tube. With a tube, you're very accurate, and that's not a problem, especially for the 2 millimeter twist drill, get you started in the right angle. However, when you just make a hole in there, you'll find that it blocks the angle. You can come in at all different angles. I can come in this way, I can come in this way, at 360 into the hole. And so, and depending on how the stent is made, this is why so many restorative dentists get upset with surgeons, whoever's doing the surgery, that's what I'm using the word empirically, is that they will not use it, because a lot of times the side of the guide, of the surgical guide, is too long, and it blocks the access visually of where the implant is being drilled to, unless you have that hole. So I think that what Arndt showed with this tube, sure, but it's more expensive unless you have your own lab doing it or your own doing it. You make it yourself with printing. But if you don't have that, it costs you an extra few $100s, and that's not a problem if you think you need it. The more implants you're missing, the more you need it, as he showed in some of the bigger cases. There's no question that will help you stay away from being in the middle of a papilla, staying out in the right angle. So for a single tooth, though, assuming the adjacent teeth are healthy, I don't use it these days at all. Part of experience, of course, having placed so many thousands of implants. But the other reality is that even for inexperienced clinicians, in the posterior part of the mouth in particular, unless it has a tube in it, it becomes sometimes a hindrance, just to check. It's okay to have it as a checkup.
Let's ask Arndt. We place so many implants, but for students, maybe it might be helpful. Arndt, if I ask you, you have 2 stents, but you don't have a lot of money, so you have to reduce one of them. Which one is more important of the 2 stents? The one that you can make by computer guided, or the one that gives you the image of the final result?
It's always, the answer is always, it depends. It depends on the case. Because if you have a difficult case, let's say you have a narrow gap and the roots of the neighboring tooth are converging, then you have to be very precise. Then you need a computer-derived stent in order to have the perfect implant position, not to touch the root of the neighboring tooth. But at the same time, if you place a single tooth for a single tooth implant, and you have a perfect smile, then you can really use the local landmarks, and you can, in some cases, go without any guide. And in a complicated case where you have a bridge work, and then I would like to see, for example, really the restorative outcome in order to place the implant perfectly. So it depends on the situation, but what I'm saying is maybe we place implants for many years and we can see which case is demanding, which is not. But to give an advice to people who are not really very experienced, it makes sense to use a guide, and I'm not saying advocating to use 2 guides, but you can use the temporary restoration as an additional guide, and to have added information during the surgery. You can disinfect it and use it and place it and see where are the tissues. That's what I'm saying.
Oh, thank you.
So
So
one last thing on that. The anatomy of the adjacent teeth is always on a single tooth. The anatomy is all there, assuming they're in the right position, and that allows you to come right out the cingulum to me without any problem, unless you have, like Arn said, a problem with 2 roots. And if you have that, then I'll go in 5 millimeters to my best angle, and then I'll take an X-ray with a guide and with a pin and see if I'm in the middle where that spot is.
But Dennis, I think your message is, don't believe in the guide at all. You can use it, but look at the situation, analyze the situation, and then start thinking. Okay.
Well, the guide is the anatomy of the adjacent teeth, and so that's what with the single tooth I'm talking about. The more you're missing, the more you need the guide. Absolutely.
Well, we all realize that the implant position is very important. There is one question that I would like to start with Thomas. With implant position, direction we have seen, we like to have a screw down, crown, and so on. But the insertion depth, that's the key. And insertion depth depends very much on the implant system, I think. So how do you tell the audience now, what is the perfect insertion depth in the aesthetic zone? They want to know.
Yeah. So I would say that first of all, why depth is important, because that's our vertical biological width for protection, which we discussed. So I think that it should be at least 4 millimeters, not 3, but 4 millimeters.
Give one information. From which point you start to measure, because I think that's very important.
I'll start from buccal. From buccal, so it goes, if it's basiodistal, it becomes deeper. But here is at least it should be 4 millimeters. Now let me.
Sorry. From mesial distal 4 millimeters?
No. From buccal. From buccal.
Buccal.
Mesial distal is always deeper.
If I may help you a little bit. Which part buccal? It is the expected soft tissue margins, the highest point of the.
Yes.
I think we have to make things clear, right?
Yeah. Thank you. That's the job of moderator. Yeah.
So you want 4 millimeters.
to keep us on track and explain what we mean.
Whether you use a platform switching system or non-platform switching system.
Yes. So for anterior case, I would use platform switching. But as you might learn, I think bone stability can be achieved with any system. But in anterior case, I would go with bone level, no polished neck, no polished color, and at the level of the bone, or depending on the system, even below the bone.
But the insertion depth, is it similar if you use a platform or non-platform switching system?
Yeah, it is the same. Because for the tissue thickness, in my opinion, it does not differentiate between implant designs.
Let's ask Arndt, do you make any difference whether you use platform switching or non-platform switching? In other words, whether you start very narrow diameter prosthetically or a wider diameter, does it make a difference?
If I have a gap in the anterior zone, I would always like to use a bone level implant with a platform switch, in order to stay away from the adjacent teeth and tissues. But in the posterior, I like to use an implant without platform switching in some cases. and then I place the micro gap not on the same level of the bone, but a little bit coronally. Because if I have a big diameter implant, and like, you know, you can develop your emergence profile from this nice diameter. So it's a different story if I place an implant in the posterior or anterior zone, actually.
I think, can I comment on that? Can I comment on that?
Sure.
I totally agree with what both of them are saying. The front of the mouth is different because of the scallop of the bone, just like Thomas was mentioning. You have an average 3 millimeter scallop of bone. So when you place it more or less 3 to 4 millimeters, like Thomas said, which I do also, from the buccal height of expected tissue or desired free gingiva, the zenith point, then you should be on, usually it's about 4 millimeters. 3 is the minimum, that's about where the normal crest would be. But that makes the implant subcrestal on all cases in the normal aesthetic case, when you have normal tissue on the adjacent surface. So the 3 millimeter, 2 to 4 millimeter scallop of the bone. So every implant that we place, every x-ray that you show when the adjacent teeth are present on a normal healthy case, single tooth, will always be below the crest of bone, 2 to 4 millimeters. So placing it a little deeper is not critical. In fact, Uli, you were the one that showed that vertical height was not critical to the papilla. Your famous article in 2010, I believe it was, where you did the 10 cases. You're welcome. We thank you. I always quote you on it. And it's not just because you're a moderator and a friend. It's because it was a great article showing that the vertical height of the implant was not critical to the papilla coming back. It was the adjacent tooth, which we all know today, thanks partly to your work. So the attachment on the adjacent tooth. But posteriorly, I think Arndt brought something interesting up. First of all, the bone is flatter. So you can get, and there's no aesthetic component. There's a soft tissue, like Thomas pointed out. The thickness of tissue in his great articles was important to bone loss. And I love that work that you've done, Thomas. It's beautiful.
Thank you.
But remember those. Yeah, remember those were all bicuspids and molars. They were not anteriors in all of your research, and that's important. People forget that. In the anterior part of the mouth, we are already 3 millimeters below the interproximal height, no matter what you do, and probably 4 to 5 millimeters, if not more, below the papilla height, the peak of the papilla. So that's very different. And I love the fact that Ernst brought up the fact that the emergence profile, he doesn't almost want a platform shift. We're using wider and wider implants to avoid that big tulip shape. You know, to come out with a bigger, wider implant allows you to do a straighter profile, which is exactly what Ernst was talking about. I couldn't agree more. We're doing wider implants in the molars to have a better emergence profile. And I think that all of which is then true. Both of you are saying accurate statements. But I think 4 millimeters is the number that I'm usually looking for. And I think part of what Uli was asking, if you go for a narrow implant or a platform shift, it does the same thing on the prosthetic part. It does a similar thing, your emergence profile, and Arndt, your diagrams were beautiful, showing that depends on the depth that you have those beautiful diagrams. Depends on the depth, you change the angle that you're coming off with the abutment and the contour of your crown. Beautiful documentation that way, beautiful graphics, because that's true. And if it depends on how deep you are and how narrow you are, will depend on the emergence profile. It's not just the depth, it's how narrow you are and whether or not there's a platform shift and the diameter of the implant, all of which will play into this. So it's a combination of platform positioning, buccolingually, depth, and whether or not there's a platform shift, all of which play into that emergence profile.
I go on with Thomas with another question. You know, we have seen all this, the concept, if you have a very concave abutment and the people, they tell us the soft tissue is growing in by itself, we gain all the soft tissue. Does this make sense?
Well, it's a tricky question. Maybe it makes sense as emphasized in the surgery when you place the implant immediately, because then you know the tissues are fragile. There is no biological width, because when you place implant immediately, it's just a hole. Yeah, there is no biological width. It needs to form, it needs to heal. So in that case, I think it makes sense to have the space, not to have pressure. But when the tissues are healed, then of course you need certain kind of the pressure to develop the stability. And sometimes if you need to move the tissues, I mean, if you need to push them a little bit further, then you make a little bit of the pressure. So I never in my 20 years of work had ischemial necrosis from the pressure. because it's the most vascularized part of our body. So it's really, I only, how to say, see the good example of controlled pressure on peri-implant tissues.
Okay, there's just one other question for you, Kim, from the audience as well. What about a cement that has a smooth surface instead of rough surface cement? If you have to cement the crown.
That's an oxymoron. You can't have a smooth surface cement. You get not the kind
That comes for the audience, sorry.
oxymoron. What Thomas showed with the great polishing will never take place on cement. It's just.
So that's it. Do you agree with that, Thomas? There is no smooth cement.
No, only rough cement prepared for bacteria. Come.
Right.
Okay. So
you know what's interesting? Only I make mention what Thomas showed so beautifully on that case that you had, Thomas, was great. That 5 years, no problem, and then suddenly 7 or 8 years, you got the problem and showed the cement. What's interesting, it seems to be, and you go back to Tom Wilson's work showing 80% of the peri-implantitis cases had cement. You know, we all know that. So, but what was interesting, it seems to fulminate. You got a great case, beautifully done, and the cement seems to fulminate. It doesn't show up like right away, not the bone loss. You might have some submarginal inflammation that we can't see, but it doesn't turn into bone loss sometimes for 3 to 5 years. And we've seen that in other documented cases, perfectly like you documented, Thomas. And so there's something that kind of builds up, and gets to a point when then the bone also gets involved, not just the sulcus getting inflamed like regular cement.
So can I comment on that?
Good.
Sure.
Yeah. So I think that then the periodontal status of the patient is important here. So here we have 2 factors. Usually people do not combine them. They say periodontitis patient and cement, yes. But that patient which I showed was young patient. So we placed the implant when 25, 24, and then after 10 years. So usually young patients do not have any periodontal involvement. And then it took a lot of years, and this was documented by Wilson, you rightly say so, that even after 10 years, you can have cement-related peri-implantitis, but usually those are young patients or non-involved patients. If that patient would be perio patient, I think in 2 years to 3 years, we would have much faster peri-implantitis development.
Let's move on.
Uli, could I say something about the contour? Are we finished with the contour, subgingival contour? Can I mention one thing?
Good.
There's a very important point about the so-called dead space that's left. And I think Arndt did a beautiful job, like I said, about showing the contours. We have to be careful about not under-contouring too much on thin tissue, unless you're thickening it with grafting at the same time, whether it be bone graft, soft tissue, connective tissue, whatever. Because then you can collapse in, and you can collapse in if it's too thin, if it's too flat, you then collapse in during the healing. If you look at Marco Deghetti's work and others, where they showed this thickening tissue, and we did the same thing, Dr. Chu and I published this with Dr. Saito, Hanai Saito, with platform shifting, we have extra thickness of tissue because we have that space right at the top of the implant. Same thing with what you showed, like on the ankylosing implant, you got a shoulder, so there's room to fall in. So the abutment then goes wider and creates that dead space. I call it a dead space, but it fills in with connective tissue, like what Thomas showed in that last case. So understand that you don't want a knife edge sticking right up. That's on the contour, and you get more tissue. But creating that space by having a bulge that comes out actually creates a dead space. But if it's all flat, you can have the risk of the whole thing collapsing in too much. You don't want too much. You want to create that dead zone for tissue to fill in during the healing phase, like Thomas so clearly showed.
Yeah. If we discuss all that, most of the cases you have shown, either you make thick soft tissue or you have thick soft tissue. And there might be a case where you have no chance to thicken soft tissue. It's so thin and it stays thin whatever you do. What do you do with these cases? These are the difficult ones. Then,
I send them to you.
But we agree, this, we have to have thick soft tissues, otherwise it's not functioning what we're discussing.
Yeah, if it's real thin, like you saw in the second case I showed, if it's real thin, you have to graft it and thicken it. That was the case with recession and soft tissue that was very weak. So no question that connective tissue graft is amazing and done. If there's no bone too, do both. As you saw me do a triple graft on one case.
There is one question that came in. what do you prefer? Take the soft tissue from the lateral palate or for the tuberosity? Always the same questions. And if I make one comment, most of the cases you don't have enough tissue in the tuberosity. Is that correct?
Absolutely, without question. When I'm looking for a big hunk of tissue, I didn't show another case with a big wedge like this. You need to go to the, the bicuspid area in the palate. And I know that Marcus is doing an incredible amount of work with the genetic makeup of the tissue. We know that tuberosity tissue might, on coverage of roots, might even swell and get a hyperplastic reaction even in the future. But both work. We've done so many since 1985 when Langer and Langer started this. We've done so many thousands of them in different ways. Both work. I think, does one work better than the other? I'm not sure. I think that one does better than the other, but certainly when we want thicker tissue for ridge augmentation, I'm most of the time still going to the palate.
Let's ask Arnd. Arnd, what do you think about the soft tissue? What depends where you can harvest it?
Most of the time I harvest it from the premolar area, from the palate. If I want to augment vertically, I need really a lot of tissue, then I go to the tuberosity, but it depends on what you need the graft for. If you want to gain a lot of volume, then go to the tuberosity, but
if there is enough material there.
Yeah, that's a problem. Sometimes they don't have it. And also the patient with a thin biotype, it correlates. They have thin tissues at the palate too, so that's a problem. So in 80% of the cases, I go to the palate.
Yeah. If you take it from the palate, does it depend whether you take deeper or more superficial? If you look at Zucchelli's way to do it, it's more superficial. You have better quality. Do you make any differentiation?
No, I take the subepithelial graft. Maybe I'm conservative, but it works for me pretty well over the last decade. So this is what I do.
Okay. Let's move on. You showed how you remove an implant. So there
are many options.
Do you still remove the implant with this technique by removing part of the buccal bone plate and then remove it and replace it?
Yeah, you have always different clinical situations. I removed fractured implants with this kind of bone lid method. So I could remove the fragment and then augment it and replace the bone lid and then implant. In this particular patient, I removed the one implant with the bone lid method. The other one I could unscrew. The other one was loose already. So it depends on the clinical situation. Most of the time, I try to unscrew it, or I use piezo surgery to go to do an osteotomy and then remove it. And if I have a lot of buccal bone, then I can use the bone lid method. So it depends on the clinical situation.
One of the questions that came in, do you do any ridge preservation technique when you take an implant out?
Only collagen and maybe soft tissue graft, but no bone substitutes.
Okay.
Well, I definitely do graft. I do immediates almost all the time. One surgery, one time when if I have my tissue and my buccal plate there.
Yeah, okay.
If it's deficient, if I have buccal bone and tissue present, I'm doing an immediate with the rarest exception of some problem. Maybe
I have my favorite question, a tricky question, Dennis. How do you take a zirconia implant that's fractured out? I love this question.
Yeah, have a good time drilling it out. Then you have to do a core of some type. We go back to the old trephine, and that really is, or I use a very thin diamond so I can be selective as to where I'm taking my.
But it's a nightmare, is it?
It's a nightmare. Thank goodness. The only time it's a real nightmare is when you're putting an implant in and it breaks because you're trying to torque it. You're putting the zirconia implant in, and I've had that happen from one company where I put the zirconia implant in. We don't use that many because they can be fragile. But we can talk about that. But when I put it in, I was trying to get a little extra depth, and the top snapped off. That's a bad day in the office. The whole top snaps off. The bottom half is now got 50 Newton centimeters in bone, and you got to now take it out and put another implant in because that's what the patient came in for, with a normal ridge. That's a bad day in the office. So I agree with you.
I have another question that came in from the audience. They actually want to know if you augment bone, place a membrane, and on top of the membrane a soft tissue graft, and there is no blood supply from the membrane side. Is this not a disadvantage?
No, you have a flap that has blood supply from the base. That's what gives you the blood supply, and that's
So
a
you
full
see
thickness flap.
the same healing, no problem.
Oh yeah, I showed it. I mean, I showed a couple of
Yeah,
cases.
you showed one
It
case,
took
but,
20 minutes. I showed a couple of cases where I did that, but it's a full thickness flap, and you have a good base, a wide base, and you're not sacrificing. You're not making a little thin opening. You're making a wide base, whether it be your kind of thing where you're doing a whole envelope, or whether you're doing it limited like I do with papilla sparing. That gives me enough blood supply, and then you have a tremendous blood supply there. And the key is passive closure. That's the key. It's not what you're putting underneath it. The key is full thickness flap in those cases, and then passive closure. You saw me emphasize that in one case. That's the key to getting success to any bridge augmentation.
And another question is, how do you decide whether soft tissue augmentation is enough, or whether you need bone and soft tissue?
Oh, yes, give me 1 minute. That's it. Well, as you saw, I did both in one case because it was such a huge depression. I didn't have enough palatal tissue. So I went for, even though there was bone on that misangled implant, like the one with the patient had with 2 implants, the laterals, where I had came in with deficiency on both, I went for bone and soft tissue. Why? Because she had a huge depression and I could never have gotten enough thick tissue from the palate. So I put in a bone graft with a membrane, increased, even though there was bone on the front of her implants, but they were misangled. I had that big depression. I did a bit of both. But I needed the soft tissue is critical on these cases that you want to change the angle. Because if it's deep enough, then you need thick tissue to change the angle and keep it there from receding. So I need soft tissue mostly, but if the bone depression is there, even if there's bone covering the implant, I will create the thickness by doing a bone graft and then do the soft tissue over that, as you saw me do.
Now I have a question for the 3 of you. You know, we always talk now about soft tissue. We all agree how important soft tissue grafts are. What about a xenograft if you want to replace soft tissue? Who wants to say something about xenografts? Why go to the palate and not open the box?
I have some experience with using a cellular dermal matrix in combination with immediate implant planning, and we did a study on that. It's a case series. We had 10 patients with a connective tissue graft and 10 patients with a xenograft, and we didn't see any differences in volume after 1 year, and also not in the pink aesthetic score. So in this indication, it works pretty well, I have to say.
What kind of indication was it? What did you use it in?
Immediate implant placement, and I thickened the soft tissue with a cellular dermal matrix.
Oh, just for a single tooth. At the time of placement, you mean?
Yes.
Or you opened the flap at the time of placement?
No, we just did a little tunneling, like a little
Okay.
and then yeah, that's it. So this indication works pretty well.
Yeah. So if I have a ridge augmentation that I want just shape, I will use like a xenograft with the membrane. That combination has held up, and Boozer certainly showed that on his early placement with his great documentation, with putting in a bioas or whatever, a xenograft with a membrane.
You misunderstood me. I want a xenograft for the soft tissue replacement, only soft tissue xenograft.
Yeah.
Yeah,
that's what I'm asking. You know, this is the new trend. You have a box where Dennis, if you have to augment your cases just with soft tissue, would you go for a xenograft?
No, if I need soft tissue, I'm going for a connective tissue graft. I can use a dermis. I've used that, and I published on histology using dermis for guided bone regeneration as a membrane. But we have some interesting case reports with histology that Dr. Fletcher and I published on. But dermis is okay to add on. I have cases like that. I didn't show them today. I didn't have time. But where I did multiple layers, sometimes of dermis, 2 layers of dermis, right out of a box. So the dermis is out of a box too. So we do that, and that does work pretty well. It's not as good as fresh connective tissue, I think, because you still get the blood supply initially if you get the fresh connective tissue. The dermis, remember, it doesn't have the blood supply to it. It's got to develop that over a few months of healing. So there is a little bit difference in the wound healing. That's why you have to cover it. You can't leave it exposed.
Yeah, so we have a really long experience using xenograft for soft tissue substitute, because our vertical soft tissue augmentation technique for posterior ridges was really developed with one of the materials we were using. This was porcine xenograft. And in terms of bone stability, it really works. And now what we're doing, and actually we're doing, and I think I will have the data in upcoming weeks, we're comparing immediate placement implant with connective tissue, and on the other group, implant and porcine xenograft. And we look at all the pink aesthetics score, all the parameters. So far as I know, because I didn't get the final data, something similar as Arndt has said, there is no really big difference between at least in immediate implant placement with a certain criteria when you have the wall and etc. etc. So I think that for simple case immediately, we don't really need to take soft tissue graft. We can substitute it with xenograft.
If you're talking about immediate, Uli, if you're talking about immediate anterior case, if you have a buccal plate there, everything will work. There's not even a question about it. To me, both will work. We've done also the grafting of the gap, as well as what I call dual zone socket management. We've published on it. It holds the tissue, and we don't have to do anything more than that. And that's what we do today. We've done it now for 7, 8 years now, probably 8 years now in the office.
The question is, does it function in every case? If you have a very thin soft tissue?
So then if it's really that thin at the time of extraction, we usually will then go to connective tissue. But what we find is that if
we always have to differentiate case to case.
It's case to case. What I have found, though, what I have found is that by placing the palate toward the palate, like we're all doing today,
and I have another point which I would like to you discuss. You know, if we take the xenograft and if we take the autograft, what we've seen, and you all have seen this, that soft tissue starts thickening over the years. Okay. And I think Thomas showed the case and said, well, we did even on the soft tissue graft and it became thicker. But isn't that an advantage? Can't that be the advantage of the autogenous graft, that it's thickening over the time? Yeah. We might lose some bone and compensate by thickening. Is this one of the point that makes sense in a concept? Let's ask with Arn.
It's not predictable. It thickens in some cases, but it's not predictable at all.
Listen, both will work with time. We've learned that connective tissue and xenograft both work once it's successfully in. Whether one increases over time, as long as you get the proper amount to begin with and it doesn't change much, we're winners. You don't need more. So it's okay to have it, but if you get the right amount at the beginning, then you're golden right from the beginning. You don't have to get it to swell anymore. Sometimes you don't even want to, but as long as you get it right from the beginning, you're basically okay. But both will work. Both will work, Uli.
You might lose some thickening, no? Soft tissue thickening, you never lose it over the time?
Well, I'd say never. Everything in the human body, everything's possible with any kind of grafting. But I think that we've held it magnificently well when we do, we're just looking for a ridge augmentation. Then we don't want something that collapses. Then we don't want allograft. We do want a xenograft that is basically almost non-resolvable, not completely, but almost with the membrane over it. That, just like Booz is showing that his work, that it holds so beautifully with the contour on the buccal. So I think both will work and not change much. I think the free gingiva can always recede on anything that you put in. Obviously, if there's very thin tissue, then I'd rather have a thicker connective tissue graft underneath, like I showed you in one of those cases.
There's just one question for you, Dennis, from the audience. They want to know how you stabilize your membrane, how you stabilize your graft during surgical procedure.
Yeah, I didn't have time to go through the details because we only had 20 minutes. But what I do is I'll put the graft in. You notice I use no tacks. I didn't use any tacks. It's held out by the graft itself, my bone graft, and then I'll tuck it in to the palate. I tuck it in, I have the little piece going into the palate, and I suture it to the palate. That's my key. I flip it over, I've trimmed it, put a piece of it underneath, but it's true of the connective tissue graft over the crest as well as the membrane. I suture it to the palate. Now, it can't be a BioGuide material. That's fine for just draping. But when I come over the top of an implant, I want a more rigid material. And so I use a more rigid membrane that has some ability to be sutured easily. So I'll tuck it in with the connective tissue to the palate and then flip it over once my bone graft is in. And that stabilizes it, combining with the sutures on the side. That's all that I need. I don't have to do anything more than that.
Can we ask Arndt, there are more than one that had the same question. When did you decide to place 1 or 2 implants if you have 2 adjacent teeth missing in the front area?
It's a matter also of scalloping of the patient. Is it a very demanding case, yes or no? What is the thickness of the tissue? What's the space there? So most of the time, and also occlusion. If I can guarantee that in protrusion and lateral protrusion, there is no contact on the pontic, then I would try to go for one implant with a cantilever, because it's more predictable to have the perfect soft tissue than there. So it
Why is
depends.
it more predictable?
Because, you know, it's in my experience. And, you know, we know the problem that the micro gap with two adjacent implants, which I tried all over and over again, but I think a papilla between two implants, I mean, two central incisors is a different story, but a central incisor and a lateral is always very demanding, and in my hands, it's not predictable. So I sometimes decide to go just for one implant with a cantilever and augment the site and do a pontic area there.
Yeah.
But the important thing is you have to augment anyway, right?
Right.
Yes.
That's
For-
critical. That's critical. You must augment that site.
Either it's in the pontic area or you have to augment. So
Yeah,
this was,
unless it's already there, and you just save it with an ovate pontic with a graft. You know, if you're doing it right away and the tissue shape is there, the tooth you're taking out, you can maintain it. We've shown that we published this, you only lose about 1 millimeter of tissue. With a graft with an ovate pontic placed immediately in, can't leave it off of the temporary, off the central. So if you look at the case that An showed with the two implants, you know, with the one that you took out, you wound up replacing two implants, a central lateral. The papilla was short there.
Yeah.
And then that second case, you did the ovate pontic cantilever. So you showed both in your examples. And the cantilever with the pontic can hold the tissue. We can get epithelium actually during that initial phase to hold on to the epithelium, can actually adhere right to the pontic, and during the healing phase, and the graft underneath. Interestingly enough, you know, no one's actually done, we did the first article on this, much to my amazement, what an ovate pontic does, how much recession takes place. I'll ask the panelists myself, how much recession takes place if you do an ovate pontic when the buccal plate's there and you do an immediate ovate pontic. Believe it or not, I asked Lenny Abrams, who came up with that idea in 1980, in his famous article, 1980, ovate pontic. And then Garber and Ed Rosenberg followed up with 2 years later. No one showed any data on how much recession takes place after an extraction with an ovate pontic. We have it on teeth and immediates. Oh, we all have that now, but we didn't have anything on pontics. We just published it last year, 2 years ago, for the first time. That's without a graft. Now, Dr. Song and myself and some people at Columbia, we're now doing it with a graft. What do you do with an ovate pontic? And you put a graft in and the ovate pontic obturates it. We're now doing that. And it's again about 1 millimeter to give you some early response. It's about 1 millimeter of height and maybe a 0.5 millimeter to 1 millimeter of width, but it can be held. And the papilla height is really going to be the critical thing that it helps keep. And Garber and Salama's article talk about it having the best results if you do a pontic versus two implants next to each other.
Yeah.
okay. There comes well, there's another question. Let's go back to Thomas. Thomas, I think you showed us nicely that zirconia, full polished zirconia is the best for soft tissue. There are a lot of studies going on, not published yet, because we have so many different zirconias. Does it make a difference what kind of zirconia we use?
I don't know.
Because, you know, everybody changed material and then we learn something and maybe it's not useful.
Well, lab technicians keep telling me that actually there are only 2 companies in the world who produce zirconia. Only different manufacturers buy, they place their stamp and they sell. So actually zirconia is really similar everywhere. I think that it's important, the surface. And what interesting study which we are doing now, we are, because I always say, you know, that I like evidence, but let's say for this statement, I don't have really a strong evidence to say that, yeah, super polished is better, because I don't. So we are now running a study when we compare normal roughness of zirconia, let's say recommended, and super polished, and we're looking at all inflammation parameters because it's difficult to say what is better. So that's ongoing thing which we're doing now. So
we switch to Dennis, and I know Dennis. Just I know you still do a lot of metal parts. You use a lot of ceramic crowns and things on, and you show beautiful results. Does it make a difference for you what material you use there?
Not from a periodontal standpoint. That is zero. I think this is a bunch of hype put out by a lot of people that love zirconia and the companies that want to push zirconia. Let's get a few things really clear. And give me 2 minutes on this, because this is so critical to understand wound healing. You can't look at, I've looked at these studies on zirconia. We can't look at just how the cells spread over zirconium in a test tube. That's nice. The surface tension matters and all that, but it's not the critical thing. Soft tissue, let's get this one right. Epithelium will adhere to any clean surface, like what Thomas was showing. Any clean surface. If it's toxic, it won't adhere. But when you take that, like Thomas said, you have that wound, a fresh socket, it's going to fill in. Yes, it will adhere. We published on this. We have hemidesmosomes attaching on it. We actually showed that. And you can get fibrous tissue to attach an epithelium to attach to acrylic too. And we published it. Dr. Saito was the first author on that one. We just published it with Dr. Chu 2 years ago. But here's the key. As far back as 1956, go back to Jens Verhaag. Jens Verhaag actually showed that he took a diamond stone and deliberately took a rough diamond stone subgingivally and like a curetting with a preparation on a tooth to see if the epithelium could go in and out of rough surfaces or smooth surfaces. He showed perfectly epithelium could go on a smooth surface or a rough surface. 1956, let's not rediscover the wheel. Epithelium will adhere to any clean surface. It'll adhere to acrylic. That's why your temporary, when it comes out, has bleeding. It'll adhere to titanium, rough or smooth. It'll adhere to zirconium, rough or smooth. Now the question is what happens afterwards. If it's highly polished, then the plaque on the sulcus may not attach as readily. And therein lies the difference. But the tissue will attach and adhere to both equally. And people who say otherwise don't understand wound healing. You have epithelial attachment always present, and it will adhere to any clean surface, period. It can be any material as long as it's not toxic.
Yeah, I agree. Epithelium doesn't differentiate. However, epithelium likes the smoother the better. So how I see it, so zirconia can be smoothest from all the materials we tested. You polish them, and for example, if you polish titanium and you polish zirconia will be smoother. But we tend to forget.
Well, how smooth is important? How smooth is important?
Exactly.
Get to a point where the epithelial cell
But another point we forget that there is data that the zirconium as a material attracts least of the plaque. If you compare with different, so just because the energy, the electrical charge is least of all the materials. So as I see it, if we want to increase our adherence zone and reduce plaque zone, so zirconia, in my opinion, is a natural choice because the material itself has less plaque attraction and you can smoothen it. But as I was saying in the presentation, it's not, how to say, a crucial point for implant survival. However, for the tissues, well, we have data what we have. So they show that tissues are better.
Let's ask Arndt in this context, one abutment, one time concept.
Yeah, biologically, I think it makes sense, but in the daily practice, it's not really practical for me. You know, it's not what we do.
If you work in a front area and you have to try in a crown, take it out, in and out, do you think you see any difference regarding result? Or you could do it, you cannot, but you could do it in one step?
No, I think we have to do try-ins and so on. So I have to remove the abutment, but I think you should, of course, do it not traumatically. You should insert a clean abutment. You should clean the surface. So if you change the abutments like 3 or 4 times and you have a clean abutment, I think it makes no clinical difference, actually.
Well, I think that.
Come back. Thomas, what do you think?
The one abutment one time is obviously started off by a few people, Salam and Gabra, but also probably Marco Deghetti has probably some of the best, results on that because he put it on, and that system that he was using he put the abutment on, and he made a cementable temporary crown, or a long-term temporary cementable crown for financial reasons, and he kind of left it in there. But he didn't keep changing the abutment, he just changed the crown. And that's okay, it's very good, you have the biology on it. The only person I know that's done repeated move on and off and showed epithelium to come back on a clean abutment, like Orange said, was Abramson. And he showed that the tissue, he did it on an Astra implant where he had the temporary, and then he changed it once and showed that he didn't get it to move apically, histologically on the animals. It stayed in the same spot. But that was one removal and then changing it right away. But multiple times we've seen the progression, similar to what Abramson and Lindy showed, showing that multiple taking on and off does cause apical migration of the attachment, you know. And so, but it can be healthy and a normal sulcus. But initially you get the attachment, you rip that adjunctional epithelium on the abutment. That's why we always see bleeding on a healthy case. On an abutment, we always see bleeding when we take the abutment off, even titanium or zirconium, it doesn't matter. We see it because we got the epithelium adhered, and we rip it when we unscrew the abutment. You've all seen that.
So let's ask Thomas. Thomas, would it make sense to have healing posts made out of zirconia?
Probably, yeah. It would be interesting to see, but I would like to comment on one abutment one time. So I think it depends on the implant placement depth. If the implant is at the level of the bone, it doesn't matter. But if the implant is below the bone, then less disconnection can, let's say, have less remodeling of the bone which is above the implant neck. That actually, we made a study on this, still not published, but we see the less remodeling of the bone which comes above the implant neck when the implant is placed subcrestally. But level of the bone, I mean, when sometimes you see videos like in a place that crestally, and then it doesn't make sense at all.
Well, remember that I think the implant you might have been using, I think had a if I'm not mistaken, had a rough surface over the shoulder. It was platform shift and it had a rough surface over the shoulder. It was blasted all the way right to the top, as opposed to a polished top. So when you see bone over the top, similar to what Wang showed, this was an ankylosing implant, and you'll see that the bone, because it's etched on the top, so that's why the bone comes over the shoulders so well. That's completely different than a polished collar. As you know, the bone won't stay on a polished collar. Bone needs a rough surface. Different than epithelium, bone needs a rough surface to integrate, as you know.
Okay,
so that's why you'll show the bone coming over.
Yeah. Time is almost over. I would like to have one last question for each of you. In the front area, how do you temporize your cases? If you have a complex case like Arndt showed, where you have to augment bone, where you have to augment soft tissue, not in immediate, already everything is destroyed. How do you temporize your cases?
May I start?
Yes, please.
Always try to go for a fixed temporary, no removables, whenever it's possible.
If you have 4 front teeth missing?
Yeah, also then I go for an you spot etched adhesive bridge made of metal and composite.
And what's the reason? It's just comfort for the patient.
No, if I want to graft bone, I mean, my enemy is always the temporary and pressure to the wound. You know, it's removable temporaries are really a pain in the back because you don't know what the patient does with it, first, and second, it's moving, and with a fixed one you have control, and you can also mold your tissues. That means you don't have the pressure, you don't have trauma to the wound and the tissues, and you can, at the last stage, you can go and start molding your tissues with Pontics, for example.
Okay, Dennis, how you handle your enemy?
Well, almost all fixed. I think I showed the bonded bridge that's spot etched for a single tooth, but we do that for wherever we can. We do bonded bridges out of occlusion and spot etched with no drilling into the teeth, just where from the incisor ledge from the incisor ledge to the contact point. We etch the enamel there and the adjacent teeth without drilling into them, and that's what we do. If we can't do it for some reason, or it's too big a span, we'll try an Essex retainer. The worst thing you could use is a flipper, you know, some kind of a partial denture. And if you do a partial denture, you should have a cast partial denture that's got occlusal rest posteriorly. If you had a long-term case, then it doesn't have any pressure on the ridge. That can work, of course, but you must not do the worst thing we do in dentistry is a transitional partial denture. It is disgusting. There is nothing good about it except momentarily replacing some teeth that you just extracted. But you lose the papilla, you lose the scallop, and it becomes flat. This is the worst procedure that we ever devised, and that's what's being taught in 99% of the students in undergraduate. Take teeth out, do a partial, do an immediate flipper, or, you know, for multiple teeth, partial denture, and then send it to the surgeons and periodontists to fix. They lose the scallop. It is the worst procedure that you can do. This is a strictly momentary thing for 1 week, 2 weeks max. And even then, it's not even, we don't even want it there. But not in the aesthetic zone.
Thomas, how you handle it?
Yeah, so I agree with Arne that we should try to do the best to go for the fixed, because we cannot rest the patients, and patients say that they don't chew, they don't wear, but actually they can destroy your work. So sometimes we do provisional implants just to put them where you can have the bone and make a fixed restoration in order to avoid the pressure on the ridge. Yeah, but sometimes you are obliged to do removable. But then just, you know, try to do it, you know, when the implants are in, then the removable must be taken out, because you can really destroy your work.
Well, maybe it also depends how you make your removable. You know, you can do it in different ways. If you make it wrong, I totally agree. You destroy everything. And the worst removal are the nylon removals. They are only soft tissue supported. That's really crazy.
Right. We both agree.
Yeah. So I think time is over. Is that correct? I would like to thank you, the 3 lecturers. They really did a great job. Thank you very much. I personally learned a lot during the presentation, during the discussion, and it's a great pleasure to discuss such a topic with the real experts around the world. So
guys, if I may say something real quick.
Yes, sure.
You see me?
Yeah.
Yes.
Perfect. First of all, thank you very much for taking the time, for joining us. Thank you, Uli, for doing a wonderful job moderating as usual. It was very entertaining. Thomas, Dennis, and Arndt, thank you very much for your great lectures and your great input for teaching. First of all, I'd like to say again, thank you. It's an experience for us and an experiment, and so far it worked very well. For the audience, I'd like to say I'm very sorry. In the first couple of minutes, we had some issues with Facebook Live. We were kicked out all the time, 3 times, but we fixed it. And I heard that some of the people that registered to the Zoom meeting were not allowed in, even though they have registered. So we'll try to fix that for the next one as well. But overall, I think that was very great. Again, we had around 2,500 to 3,000 viewers at one point in time. So that was very great. And thank you very much.
Can
Thank you for doing it.
Thank you so much.
Bye, everybody.
Bye-bye. Thank you so much.
Wait quickly.
Uli,
It's
Uli.
important. There is a chat. And while listening to you, I went a little bit through this chat, and you can't imagine how many compliments they made you. There's a great lectures, great discussion. They really, yeah, you should see this. You would be ashamed, because they really said it's just amazing what you did. And I think it's important. And
Thank you so much.
one last thing, stay healthy.
You too.
Okay.
Bye-bye. All the
Thanks,
best.
everybody. Stay
Love
healthy.
you all.
I hope to see
Bye-bye.
many of you next
Bye-bye,
Thursday.
everybody.
Thank you, guys.
Thank you.
An honor. Thank you so much.
Bye-bye.
Thank you.
Bye-bye.